Let's start off with the Rehabilitation Series Course 1, where we're going to be talking about maximizing recovery after stroke. And in particular, we're going to be looking at how to increase your patient's attention, their awareness, and also deal with sometimes the problem of neglect, and looking at how to change the brain through neuroplasticity. So thanks for inviting me, Mohamed, and thanks for joining us, all of you that are out there watching this live or in recording. So let's get started here and let's look at what we're going to be up for today. The course timeline for this first course of a 4-course series, today's effort will look like this. We're going to talk about stroke mechanisms and also the prognosis and how to time our rehabilitation efforts. After that, we're going to talk about attention, and we'll move into our efforts to move into awareness and dual task, and we'll do a little bit on neglect as well today. I'd also like to extend time for all of you to interact, both with me and with each other, so we'll have time for questions at the end as well. After this course, we will then present a course where we dive a little bit further into neglect and into awareness and impulse control, and even matters of alien hand syndrome. Then we'll do a 1-hour course after that that is entirely devoted on arm recovery after stroke with some new research opportunities and advances. And then the 4th course in the series will also be 1 hour in length, and we'll devote our attention toward lower extremity recovery for walking, balance, transfers, and so on. Just a little bit about me. You'll see that I've been a physical therapist for now going on 35 years. I've been board certified in neurologic physical therapy for 30 years, and you'll actually see that I still practice clinically, but I'm also on faculty at 2 universities. I teach throughout the world, as with our efforts here today, publish articles, books, and also lead research projects. For those of you that want to reach out to me directly and your question hasn't been answered by us today, or if you have a case to go over with me, the best thing to do is email me right here. And do know that if you want to follow me on Instagram, as many of you already are, those handles are down there. And I have a book for purchase that is entitled The Brain That Chooses Itself. The objectives that I would hope that you'd be able to, let's just say, complete by the end of today's course is that you can understand the principles of neuroplasticity for stroke. We're going to translate that into multidisciplinary physical, occupational, and speech therapy contexts. We're going to look at how to rehabilitate attention specifically today, and look at the concept of dual tasking, and then also dive into the matters of neglect and awareness. We're going to cover right hemisphere dysfunction to some degree today, and then also even more in depth in the next course. And we're going to start right off with this first concept of ischemic versus hemorrhagic stroke, so that I hope you'll be able to appreciate the differences there. Now, the first section where we talk about stroke mechanisms and timelines helps us to understand the neurophysiology of stroke, because they're not all the same. So we're going to be looking at what's safe to do within the first 24, 72, and 1 week after stroke. And we're going to see what we do in the rehabilitation clinic that helps to promote neuroplasticity, including some of these main factors here: brain-derived neurotrophic factor, glial-derived neurotrophic factor, insulin-like growth factor, and what we can do to promote neuroplasticity. Throughout our time today, if you have a question, feel free to go ahead and add your comments in chat or in questions. I'll be able to field those either way. Mohamed is my colleague, and he'll help me look at questions. But do note that I'll also save time at the end for your questions. don't feel like you're going to interrupt me. I want to interact and collaborate with you. In this section, we're going to look at that pathophysiology of the different types of strokes, and then also neuroplasticity, how the brain reorganizes, and what you can do to promote that for your patients. First and foremost, we have to know that this figure represents every stroke. We have an area of cells that are going to be gone and they'll never come back. That's known as the zone of infarct, and that's what you see here. That's in orange. Outside of those cells that won't come back, we have two areas of viable neurons that are in shock. So when we have spontaneous recovery, that recovery comes from these other two areas, the area of penumbra and oligemia. What's important here to understand is that all three of these areas, normal tissue plus these two areas of shock, will help to contribute to the recovery that you're seeing in your patients through spontaneous improvement and neuroplasticity. Additionally, patients can also improve by compensating. We can only compensate using normal tissue to replace the actions of those tissues that are gone. And when we compensate, we are leaning on a cane, we're using a wheelchair, we're tipping our head differently so that we can swallow safely, we're changing the approach or the sequence that we use to get dressed. Those are compensations. That's part of recovery, and it takes some learning over in this area to figure out what compensations will work to keep me safe or get me independent. As I mentioned, neuroplasticity comes from this area and this area, as well as normal tissue. This is the main emphasis of what we want to cover today, is how to promote neuroplasticity. All right, so keeping in mind that recovery and compensation are different, let's be clear about how they're different. Recovery means restoring connections and having an individual move like they used to move before the stroke. Compensation means we're using devices or other people or have changed our approach. How we get out of bed, how we get dressed, how we walk has been changed. Both of them will contribute toward independence, and both of them require learning, so both of them require neuroplasticity. Recovery is going to be our main emphasis today because we want to help people get back to as normal as possible. And that's done, we promote connections by using high-intensity therapeutic exercise, functional retraining, doing the activities that they need to relearn how to do again, and also giving them some challenges inside of functional activities. So we elevate the difficulty in ADLs, and then we remove that difficulty so the brain can have an opportunity for some wins and to have improved. Here's why knowing the difference between an embolic stroke and a hemorrhagic stroke is important. Now, we know that most embolic strokes are blocking an artery with a blood clot or some sort of thrombus, which could be also called a fatty embolus. So we could have basically collections of cholesterol or calcium or a blood clot block an artery that causes ischemia, low blood flow. That's about 80% of strokes. The other 20% are hemorrhagic, where blood has escaped out of an aneurysm or some sort of artery defect with high blood pressure or something that was a change and malformation of how the brain's arteries were developed. Now, the clinical significance here is very important because in an ischemic stroke, these people are ready for rehabilitation right away. Remember, that's about 80% of people. They've in fact incurred a brief interruption of blood flow, and you'll recall that zone of infarct has a small collection of cells that'll never come back, and they have some degree of spontaneous recovery. This person is medically stable and ready for rehabilitation. That is not the case as quickly for a person who's had a hemorrhagic stroke. That person needs 48 to 72 hours, if not a full week, 168 hours, to be able to become stable and ready for aggressive rehabilitation. Let's be clear. Both of these patients should be getting up out of bed. They should be balancing. They should be walking if they're able. They should be dressing themselves. But only the ischemic patient could be working on higher speed walking, more aggressive therapeutic exercise that causes them to act or exert with greater intensity. Both can be mobilized. The person with the hemorrhagic stroke has an area of penumbra and oligemia that hasn't quite stabilized yet. So if you go back and you take a look at what I showed you right here, people that have a hemorrhagic stroke have very large areas for spontaneous recovery, but they're not ready to recover and demonstrate this unmasking of these areas that are in shock for the first 3 days to 4 days, and sometimes as long as 2 weeks. So they can look like they've had an extremely severe stroke because this entire area is how they present. But 2 weeks later, they might only look like this, and they've experienced recovery from the cells that were in shock. People with an ischemic stroke have very small amounts of spontaneous recovery. They're ready for rehab right away. So a quick question, you can feel to chime in and make an answer either verbally or through the chat or through Q&A. The question is, which of the following fact pairs about neuroplasticity after stroke are correct? Most strokes are ischemic. People with ischemic stroke can make spontaneous recovery, but cannot improve through neuroplasticity. Consider for yourself if that's what I said. Or, most strokes are ischemic. Only those with ischemic can use neuroplasticity. Or, people with ischemic and hemorrhagic stroke can both improve through neuroplasticity. Those with hemorrhagic may take longer to start improving. Or finally, people with hemorrhagic strokes, in fact, should be able to make more short-term gains in comparison to those with ischemic stroke. Now, I'll look to see the answers that you have all put forward, and I won't be able to, let's say, oh, wow, everybody's gotten it correct there. Answer being C. Yes, in fact. Great. Wonderful. Yes, the correct answer, as a matter of fact, is C. People with ischemic and hemorrhagic stroke can both improve through neuroplasticity. However, those with hemorrhagic can take longer to start improving, 48, 72 hours, and we try not to do anything intense with them, but they can mobilize early. All right, so now let's move forward and figure out how we can make the brain reorganize using neuroplasticity. In your rehabilitation efforts, you need to actually demonstrate to the brain that there is something else possible and something else necessary. You need to be able to balance yourself. You need to be able to move that arm. You need to be able to lift that leg up. So we need a stimulus. We need some hope, letting the person see that they are making some headway. And we need to actually also give them some errors. So we can't give them a perfect opportunity to succeed every time. Otherwise, the brain says, oh, I guess I'm doing fine. There's no need to make a change because every single time I try, I'm successful. The brain's only going to make a change when it sees the need for something, when it demonstrates some improvement, and when it's not getting the task right every single time. So, what happens in neuroplasticity is many different physical functions in the brain, chemical, physical, and psychological structures are going to actually undergo change. Some of it involves making new synapses, synaptogenesis, making new connections that weren't there before the stroke. Some of it, neuroplasticity, involves delivering new blood flow. Some of it involves neurons branching out so that they can be more easily communicated with. Some of it involves making connections more efficient and robust. Some of it involves actually making new memories, consolidating them so that the individual has changed their operation for walking, dressing, feeding, etc. So all of these go under the umbrella of neuroplasticity, and it's up to you as therapists to stimulate these with repetitions, with errors, and with hope. So some degree of success is necessary, but not successful every time. Now, many of you, my esteemed colleagues, are familiar with a paper in 2008 known as the Principles of Neuroplasticity. You'll be familiar with some of the things that these go by. Use it or lose it. If the brain has not activated a certain memory or a task or a process recently, the brain will lose that process. The reverse is also true. If we use it, we may improve it. You're also familiar with the next three. If you want someone to improve in walking, you should practice walking. If you want them to improve in sitting balance, you need to practice sitting balance. That's the concept of specificity. Now, the other two are the only ones that I'm going to go through today, and that is we need to give our patients some exposure, meaning repetitions. And finally, intensity matters. And intensity is something we're just now starting to understand better, because intensity doesn't have to be, I got your heart rate up to 150 beats per minute. Intensity can be, this was difficult. My brain saw this as challenging and tried to elevate my attention and my alertness. So intensity helps to make repetitions more valuable. If you only have repetitions, people won't change. And if you only have intensity, but you only give them 1 or 2 repetitions, people can't change. You need errors and successes on repeat. And you need to do that in tasks that feel familiar and meaningful to the people we're working with. However, in 2024, I introduced some updates to neuroplasticity because it doesn't just depend on the 10 things you saw on that page. We now know 5 new things that must be included for us to make a significant change in our patients recovering from stroke. Number 1, engagement matters. Is the task meaningful for the person that we're working with? Are they engaged? And that is going to lead us into that next section where we, in fact, talk about the fact that individuals need to have activities that they feel are meaningful and that they, in fact, are seeing themselves improve with. In addition, we know that sleep matters. You can't consolidate new memories unless you are getting sufficient sleep. But we didn't appreciate that as part of neuroplasticity until last year. Another big matter that we're going to talk about today is automaticity, helping our patients put movement in the background again. So that is to say, we're going to help these patients improve so that they don't have to think about moving their leg, think about moving their arm. They can do that with a degree of automaticity. And then finally, two other points to help fully engage and keep our patients alert. We want to practice in environments that feel real to them, and we want to respect their preferences for success and failure and what rate or frequency is feeling healthy to them. So now it looks as though there's an extraneous mark here. I'm going to escape out for just a second, discard these notations, come back in. I wonder why we still have that mark on there. No problem. We will just ignore that. It was made by another one of our colleagues on the screen here, but it's okay. We'll ignore it. So the stages of learning that we want to be attentive of so that we understand what a person's ready for include three different stages. The cognitive stage, when someone's just learning about the fact that they've had a stroke. The associative phase, when they're starting to learn how to use their body differently. And finally, as I mentioned, the autonomous phase, when the person is starting to be able to move in a manner that feels automatic again and does not require so much thinking. We have to understand that our approach to promote neuroplasticity is going to be different depending on what stage of learning each person is in. Here's why. In the cognitive phase, we've got a person that's a novice. We cannot bombard them with dual tasking or distractions or a lot of feedback when they're just trying to concentrate. In the associative phase, we're starting to see that the person remembers some rules about how to put the shirt on, how to lock the brakes in the wheelchair, when to advance an assistive device. We need to start to decrease the amount of feedback that we're giving, and we can start to introduce more variety in our contexts and our tasks. And finally, in the autonomous phase, we are giving this individual a more challenging expression of therapy where we're going to try to distract them. We have them try to take what they've learned in one setting and also apply it to another setting that they've never experienced since the stroke. So we're asking for some transfer of training. So now you go back to the stages of learning and you see that as they progress, we give more variety of practice, more repetitions, decreasing frequency of feedback, and in fact, we see that these people get more variability and not the same repetition over and over and over again. All right, so repetitions are beneficial, but by themselves, repetitions won't make enough of difference. So repetitions need a degree of error and intensity for the brain to consolidate and see that that was meaningful. So when they go to sleep at night, their brain takes meaningful experiences to consolidate those. Okay? Now we understand again, intensity is very helpful, putting a marker on the person's brain and causing them to see what was meaningful to store that night in consolidation. But if you only experience intensity, perhaps the task difficulty is going to be too high. You don't feel hopeful. You never experience a win, and therefore you never think you're actually improving. So too much intensity is not healthy. In addition, we need to understand that intensity is more than just aerobic exercise, more than just heart rate. So for us to be able to express exertion and difficulty, we want to make certain that our intensity is in keeping with how this individual would prefer to be challenged. If they feel like they're failing, they're not going to, in fact, see changes. So we've got to make certain that this individual feels like the intensity is in keeping with what they prefer. Now, let's keep in mind that intensity by exertion is what will get us all four of these things: lactate, brain-derived neurotrophic factor, insulin-like growth factor, vascular endothelial growth factor. All of these promote neuroplasticity through elevated heart rate or resistance training. All right, so then we have to understand task specificity. And task specificity helps us to know that when we are intense and repetitive with activities that feel engaging and reality-based for this individual, now the individual sees some person-specific engagement, and in fact, they are going to be able to continue to make big changes because things feel salient to them and they feel productive. Adaptability is important along the way, so we don't give so many repetitions in a row of the same activity, because people stop paying attention to the same activity when it is given over and over and over again. So we give people adaptability through a variety. You have 45 minutes or 60 minutes to work with someone. If you give them some walking training, then some sitting balance training, then work on dressing, then go upstairs, then come back and work on walking, this helps the individual to generate motor plans just like they need it when it comes up in real life. So it's much more real world relevant. Adaptability can be given in a manner that helps people temporarily become engaged and increase their attention, because we increase the pressure. How fast can you do this? We increase the fatigue. Can you do 10 more repetitions? We increase the distraction. Can you also do this while you hear me talking to you? And we do know that we can help to reduce tone in patients by making them more adaptable. If I'm driving in a very crowded, busy street in Cairo that I'm not familiar with, I might grip the steering wheel very tightly with a high degree of muscular tone. In the same fashion, your patients who aren't used to walking in a busy sidewalk or a distractible area will increase their tone. By exposing someone on a regular and intermittent basis to activities and environments that cause them to feel slightly provoked, they become more tolerant and their tone gradually goes down, just as you have experienced as you've learned how to drive or walk in environments that normally would have been challenging for you. So the clinical translation, to wrap up what we've gone through so far, is that we know that ischemic stroke can be stabilized earlier and can be ready for earlier rehabilitation. We expect individuals can improve through neuroplasticity in motor skills, in sensory skills, but as we're getting ready to advance into, also brains can make changes in cognitive skills. We do understand that having an individual participate in therapy where they are successful every single time is not going to stimulate neuroplasticity. And finally, we need to give repetitions plus intensity so that we can stimulate changes in the brain that we know as neuroplasticity. All right, so now we're going to actually cover disorders of the impaired attention and neglect systems post-stroke. So we're going to look at what happens when an individual's lesion in the brain has caused them to neglect one part of their world or have insufficient attention across the world. We're going to look at how to test it and how to rehabilitate this. Now, when we're talking about cognitive impairments, there are many things that can happen from a stroke. We'll cover some of these along the way in this chapter, but do know we wouldn't have time in a 2-hour segment to cover all of them. The most common cognitive impairment that affects attention is right here, right hemisphere dysfunction. Now, a right hemisphere dysfunction, typically a fronto or parietal stroke, will limit an individual's ability to be able to pay attention to anything coming in from the left side of their world. Many of you are familiar with that as left neglect. That is not the same as, but can often occur with, the loss of vision for the temporal side of my left eye and the nasal side of my right eye, known as homonymous hemianopsia. We won't talk about that so much today because that's not a cognitive impairment. That's actually a visual impairment. Please do also note that people can acquire cognitive impairment from a stroke that can leave them with limited impulse control. They're not behaving safely or taking their time. They could also have cognitive and dementia-like impairment from a stroke. They could have dual task intolerance, depression, or ebulia, leaving them without the sense that they have much to care about. Staying focused on impaired attention, we have to understand that we'll separate that out from losing vision, hemianopsia, but it can also come concomitantly with losing sensation in your left hand, perceptual loss of, in fact, is this even my left hand? And then finally, which we'll spend a great deal of time on, and that is central regulation of attention, where people tend to only be attentive to activities and stimuli on the right side of their world. All right, in right hemisphere dysfunction, which I told you we would stay focused on for the most part, this is the most common syndrome of inattention. It can happen with homonymous hemianopsia, but doesn't have to. It's separate. It is typically a perceptual loss and a regulation of attention loss, where people perceive everything of their world is over on the right half of their world. And even when they don't have visual loss, stimuli coming in from the right side are preferred even over stimuli they could see coming in on the left side. Many times, right hemisphere dysfunction includes poor impulse control, acting in a manner that feels unsafe. So let's reiterate. Neglect comes typically under the umbrella of right hemisphere dysfunction, most common. Reduced impulse control, reduced awareness about what my problems are, and may in fact also include visual loss. We treat neglect in one of two ways, but it doesn't have to be exclusive. In a top-down fashion, we help people overcome neglect by helping them see the consequences of their problems, and they can learn that they've committed the same problem previously, and they can learn from a top-down, oh, I remember I've done that in the past. I should try not to hit the door jamb with my wheelchair again and again as I try to exit the room. Top-down means the brain is understanding and learning and changing your approach. Bottom-up means I'm actually talking to the brain by way of the extremities or the environment. It's bottom-up. You can find the bottom-up approaches, including a wristband that is on a regular basis giving a signal to the brain. Remember the left arm, it's right over here. Feel that electrical impulse. Remember to look down at the left arm. You can also use caloric stimulation of cold or warm water in the ear, or visual stimulation where you end up patching one eye to force the individual to prioritize the other. The bottom-up approach takes some patience, but the two can be combined for the greatest degree of success. Neglect intervention always starts with awareness, though. If someone doesn't realize that they're neglecting the world or their body, their rehabilitation is not going to be as successful. So we want to remove some sensory strengths. So we cause the individual to start to perceive their world without dominating vision. And we may have them close their eyes or patch their eyes, and we let them feel some degree of error and consequences. Now, people that don't have any awareness are known as an individual with anosognosia. People that don't know they've had a stroke have a, which is the prefix without, nos, they don't recognize or they're not aware of their problems. Anosognosia can cause the individual to believe that you're pushing me over. It's not me that has pusher syndrome. You're holding me back. It's not me that's running my door into the door jamb. You're twisting the shirt up. It's not me that can't figure out where the right sleeve is. People with anosognosia tend to be more paranoid. So how do we rehabilitate them? People with anosognosia need to have higher levels of consequences. We keep them safe, but we allow them to fail in our protective hands. People that have awareness are different than people with anosognosia. We increase the error. We increase the challenge for them. All right, so now let's look at the neuroplasticity of neglect a little bit more closely. If someone has lost vision, we will give them tasks where we'll take an item, put it into the room, and ask them to find the item, and we can assure to them it's there in the room. That could be that they're looking for their other shoe, they're looking for a sock, they're looking for their cane, they're looking for their caregiver, or they're even looking for a door on their way out of the room. And if we set up the situation so that we routinely provide the stimulus that they're looking for to be on their left, they gradually learn from a top-down fashion to recall to look left, because sometimes if they can't find it, it's going to be because they're missing it on their left. So if you have hemianopsia, you work with a patient, you set them up in a room and say, I want you to try to find the doorway, and you position them so that the doorway is on their left. You have them also work in therapy to complete a picture. Maybe it's a picture that they're familiar with, and maybe they're putting puzzle pieces in, or they're drawing, or they have to describe that picture, and the essential elements are on their left. They have to maybe sometimes tell you what's missing in a very famous building or a picture, and they in fact are describing what is missing that's on the left. And many times we can also give them an obstacle course in walking or in propelling their wheelchair, so that the only way they can find their way out of this obstacle course is if in fact they start to look left. I'm going to take a question now that we've got populated here, and we'll go down to see that. Yes, hemianopsia is a synonym. It's the same thing as hemianopia. Yeah, very good. Now, if in fact our problem is not hemianopsia or hemianopia, and the fact the problem is neglect, you may find some alternate strategies to be helpful. You can have one person who has neglect work with another individual in your rehabilitation center that also has neglect, and they try to work together to get a coat placed on. That helps both individuals improve. If you cannot pair two individuals together, it's okay to have the individual that has neglect try to put a coat on someone else. Also, body neglect is restored through bilateral tasks, pushing a wheelbarrow, performing an arm bike, lifting a laundry basket, and so on. Body neglect is also helped through mirror activities. Do something with the right, now repeat the same with your left. It's also improved through tracing, having to actually look at body parts and cross midline. And then finally, body neglect is also improved through dual tasking. Now, you remember to look left. Will you also remember to look left when I give you stimulus after stimulus on the right and then sneak one in on your left? People can learn how to compensate and watch for items on their left when they know that's what the therapist is targeting. People that have recovered well have the ability to be able to tolerate another stimulus coming on the right, follow that with a distracting stimulus that's on the left, and still be able to look left. So you want to distract people when they've improved, and I'm going to try to entice you to look to the right and see if you still forget about the left. All right, so the error dosage in neglect, remember, as I told you, we want to increase the level of difficulty so that the patient is stimulated neuroplastically to improve. So you can give people a physical demand, and that physical demand could be elevating the difficulty of the task so that you've given them a whole body task or a bilateral task. So that's just one way to do it for physical demands. If you want to make a task more difficult so that they can overcome their neglect and you want to make it more complex, you might give them the assignment to finish both breaks on their wheelchair or the leg rest in their wheelchair, or in fact, actually perform a car transfer. Another way to elevate the errors in neglect so that the patient is stimulated for neuroplastic recovery is to distract them on the right, as I mentioned, or to hold a conversation, somebody coming in from the left, or to have them listen to walking directions and remember those and also apply the lefts and the rights. Finally, another way that you can elevate difficulty for a person that's improving in neglect is by applying a command or an expectation of pressure. And that could be, how quickly can you make it to the restroom, or how quickly could you get dressed? That causes them to work harder to be more efficient. It elevates intensity and stimulates neuroplasticity. In addition, you could superimpose pressure by giving them a task that requires them to be more accurate. Otherwise, they would incur a consequence such as a loss of balance. We never let patients get injured, but by elevating consequences, we elevate attention and intensity. All right, let's keep in mind that the way we talk with our patients will influence, in fact, how they are able to recover strategies on their own. Meaning, if we continue to give patients all of the answers and we give them constant feedback, they never have to think for themselves. So when they're not in your presence as a therapist, they don't know how to problem solve. They don't know why their wheelchair is continuing to go in a circle, why they can't get out of the doorway, why they're losing their balance, because we've never given them an opportunity to try to problem solve for themselves. So now I'm giving you a framework that helps you systematically cue patients so that they don't become reliant upon you. And here's what that looks like. The systematic cueing strategy says that when an individual faces a problem, rather than solving the problem for them, we keep them safe, but we allow them to recognize that the problem is occurring. Now, that could be them trying to get up out of their wheelchair and they're losing their balance backwards. It could be them putting a shirt on, but they're twisting the shirt up, or they've put it on inside out. It could be them, again, as I've stated in the past, wheeling their chair in continuous circles. If we solve the problem immediately, individuals don't learn how to recognize problems. So we need to give them an error and allow them to experience the consequence of their problem. If they continue to have the error and they see the error, they might generate a new solution. Oh, that's right. I bet my brake is on my left side, and that's why that wheel's not turning. And then they solve the problem. When patients solve their own problem, and we've been patient, allowing them to do that, that helps them for the next effort or the next time they face that problem. If we step right in and solve the problem for them, they're unlikely to recognize it on their own in the future. So what happens when they recognize an error but implement the wrong solution? I see that I'm turning around in circles. Maybe I should put my foot down and try to steer with my foot. We still need to let that error occur and let the patient try to attempt to implement their solution, even if it's wrong. After they've implemented a solution that is incorrect or errorful, we can then give them an indirect cue. I wonder if there's something that's holding the left wheel from turning. That's an indirect cue. And they say, oh, that's right. I bet it's my brake. I've solved it. If after an indirect cue, I wonder if there's something holding that wheel, they don't get it, that's an error, and we might give them a direct cue. You've left the brake on your left wheel. You'll notice that if they have that first problem and we go straight to a direct cue, the patient never gets a chance to recognize or problem solve on their own. And it doesn't matter whether the problem is an inverted shirt, a locked brake, you're swallowing incorrectly, you've put the cane forward and then you moved your right leg instead of your left. It doesn't matter what the problem is. Patients only improve when they see the problem and get a chance to actually solve the problem on their own. So, as we move deeper into attention and maximizing exactly what we said we would do today, we recognize that attention has 5 subtypes. Focused attention, your ability to concentrate on one item. Sustained attention, your ability to concentrate on one item for a period of time. Selective attention, your ability to concentrate on one item and extinguish or ignore other distractions. Alternating attention, your ability to move back and forth between 2 different stimuli, never both at the same time. And finally, what we'll spend the majority of time on today, where the greatest amount of evidence is in divided attention. I can pay attention to what you're telling me as I'm walking. I can listen to the radio program as I get dressed. I can, in fact, think about what I'm supposed to be doing today, what I'm supposed to buy at the grocery store while I'm propelling my wheelchair. So we want people to have the ultimate level here of dividing attention so that their ability to walk and balance and dress and propel a wheelchair does not take a hit or sacrifice when their mind is also doing something else. Now, the way to test attention is very clear. There are many different ways to do that, and I've only shown you some here on the screen. Drawing different figures. Did they draw both sides of a face, both sides of a flower? Did they represent the entirety of a clock? Recognizing in a very famous picture here called the cookie theft picture. This is a test of attention. Doing the trail making test where we have them go 1A, and then we have them find 2, and they go to B, and then we have them go to 3, and then to C, and so on. So that's alternating attention. In this situation, we have individuals attempt to potentially look for the number of A's and cross out the number of A's or do a star cancellation. Here you might pick any one of these letters and say, cross out all of the O's that you see. And we look to see if they only find the ones that are on the right side of the screen or the left. And then we do a line cancellation task is actually another way to do that as well. Okay? So here you see all of those now. There's that 1A, 2B, 3C, 4D, 5E, and so on. And obviously, in your language, you would have the opportunity to do this with characters and numbers back and forth as well. That's alternating attention. I'd like to share a video with you now so you can actually see some new ways of being able to detect alternating attention. As I begin to play the video, I want to make certain that we've got the settings correct and that all of you can actually see the video. So, Mohamed, if you would unmute for just a moment, and when I start the video, tell me whether you can see it on your end, please.
Okay. Yeah.
12 and L. It'll be L. 12 and L. Okay. On your mark.
Can you see that okay?
Set,
Yeah,
go.
fine. Here.
2D, 3C, 4D, 5E, 6, 7G, G, 8H, H, 9.
He skipped I. So this is a way to be able to measure alternating attention and mobility at the same time. All right, now when we go to another way, a more common way to test divided attention, this is the timed up and go cognitive. So having an individual stand from a chair, walk 3 meters, turn around and go back, we measure the amount of time it takes and we ask them to subtract by 3s. That's another measure of divided attention. Here's yet another measure of divided attention that's being developed. This is the 4-square step test. I'm going to measure him doing it in single task.
I've got you as 6.99 seconds on that.
Okay?
That's
6.99 seconds.
Everything was accurate there. So
now he's going to do it in a dual task fashion.
The topic of conversation, and I want you to just tell me something that you would like to hop on a phone and speak with a friend about. Tell me what that would be.
My preparation for the senior club championship
Okay.
golf event.
Okay. So then what I'm going to have you do is just...
So you'll notice I let the patient pick the topic so it feels meaningful and salient. Now he has to actually give me that topic in words while he's doing the balance test.
Words, and you just think, what are the ingredients that are going to help me be ready for the club championship? When I say go, you'll begin naming those essential ingredients in that conversation, main themes or bullet points. I know you've written a lot of speeches, and you'll do that and the movement at the same time. Are you ready?
Yeah.
And begin.
So I know I need to put a new putter in the bag in order to be prepared. I also need to make sure that I hit the ball in the fairway.
Good. So he's giving himself some advice. Now we're going to do that in a different way.
18, 22.
Good deal. All right. I'm going to stop the video here, and then we're going to add a different... Actually, I'm going to let it run. I'm going to add your different...
Now he's going to do a brand new type of distraction here.
So Jim, so far we've done a cognitive distraction
Yeah.
and an auditory distraction. Now I'm going to give you something that's a little bit more of a visual.
Okay. Now he's going to be given some playing cards and he has to try to memorize the playing cards visually as he's engaging in the balance task.
Over, you do the best you can to get the time and the cards memorized.
This would be a visual distraction.
You'll actually tell me the cards while you're holding them against your chest. Okay? You ready?
So
You're looking at them during this.
while I'm doing it.
Yes, sir.
Okay.
On your mark, get set, go. Oh, you can look at the cards, though. Yeah, let's start over again.
Okay.
So go ahead and put them back.
Lots to think about.
Now, do you want me to give you 4 new cards?
No,
Okay, all right, here we go. So remember, you can look at them as soon as I say go.
and I can spread them out.
Whatever you want to do.
Okay.
On your mark, get set, go.
So this is a visual distraction. And now we record how much time it takes him to get around while he's being visually distracted.
7.64, Jim. All right, now put
Okay.
your cards up against your chest.
Score was
I'm gonna take
7.64.
from you. All right, Jim.
Now he has to tell me
What
the
cards?
cards.
Oh,
He got them.
Okay, and what kind of suits do you have for me?
All right. So now there are many different ways to test attention. Many of those new ways are being developed right now. I've researched many more of them. What's most important is that we learn how to rehabilitate attention after stroke. And I'll tell you that there are 8 distinct ways to rehabilitate attention, and they're all listed here. Some of which we've covered a little bit and we've hinted at. Let's go through all 8 ways now. So one way to maximize attention in the patients you're working with is to let them know that the material we're getting ready to present to them is going to be on a test. Now, we all know when we hear there's going to be a test, we elevate our attention and we try to focus so that we can hold on to the information. You do the same thing for your patients as one of 8 different ways you can maximize their attention. I'm going to show you how to get dressed. This is the proper approach. Now I'm going to actually move to another task, and later on, I'm going to test you in your ability to recall what I taught you. And you can use that to elevate attention for dressing, for sequencing an assisted device, for using a wheelchair, for bed mobility, for meal preparation, and etc. A test. Another way to improve attention, remember we're going to go through all 8 of them, is to give the patients an opportunity to predict how well they're going to do. So, before they start a task, any task, walking, balancing, dressing, or otherwise, you ask them to predict how well they're going to do with some sort of objective statistic associated with that. How many steps do you think it's going to take you to get to the end of the hallway? How many times do you think I might need to help you because you've lost your balance? How much time do you think it's going to take for you to get your pants on? When a patient makes a prediction, it is by human nature that they're going to elevate their attention to see if their prediction came true. Let's field your question now. Yes, Reem says it is like as metacognition. That is correct, 100%. Now, when we look at the next segment of how to maximize attention, we can make a task just slightly more difficult. You'll recall I gave you this table already earlier in the lecture intentionally. If you want to maximize someone's attention, you say, okay, I see how you did there. You did extremely well. I'd like to make the task a little bit more challenging to see how well you can do when it's more challenging. And remember, there's 4 different and only 4 different ways to make a task more challenging. If you go back in the handout that we gave you, you'll see that you can make a task physically harder. You could add weights to them. You could increase the speed. You could make it a lower surface to get up from, or a more complex task, a harder shirt to put on, or add distractions, or add the nature of pressure. Can you do it faster? So that's a way to increase attention. We also increase attention by giving people the real sense that they are getting better. This is working for you. Let's do more of it. And that's extremely clear for you here in this slide. Keeping people hopeful. Sometimes the best way to keep them hopeful is to give them the measure or the number that signified what they were able to do, and then give them the measurement again. This is your best score on the timed up and go test. That's your personal best. They see hope and they do something that we call gamification. We also know that we're going to maximize attention through goal direction. And that is to say that when we have an individual focused on completing a task, they're more likely to elevate their attention as compared to when we focus their attention on a body part. So we want goal direction to increase attention. We don't want body part. We don't want you to think about, don't move your leg this way, or don't lift your shoulder blade up that way. We want you to be focused on accomplishing a goal that maximizes attention. Now you'll recall earlier I told you one way to elevate attention is to increase intensity. So making a task more difficult by making it more physically exerting or more challenging will also elevate intensity. Remember, if we get too much intensity and not enough success, some people by their personality will regress and not learn. So intensity has to be personalized. Along the way, we do know that we're going to maximize neuroplasticity if, in fact, we elevate intensity, and here's why. Because attention and intensity will come together and promote these three main neuromodulators in the brain. They'll tend to decrease our cortisol when we're seeing ourselves as successful, decrease our tone and adrenaline when we become more comfortable with an environment because we've done it more than once, and in fact will promote a lot of fertilizers in the brain that we've already talked about. One thing that you might not be as familiar with is lactate, though. So exerting against resistance or exerting so high aerobically that you cannot deliver oxygen fast enough to burn energy causes us to produce lactate. Lactate, when it builds up, signals to the body to release food to the brain. Brain-derived neurotrophic factor, growth factor, and it also substantiates or reinforces the blood-brain barrier. Lactate does all of these things. Blood-brain barrier feeds nerves and a signaling molecule to cause these to be released. So that's one of the main reasons why we want to occasionally elevate intensity again. So recall, maximizing attention will include these things. And now let's add in just a little bit more into dual tasking now. As I've already alluded, dual tasking is the concurrent performance of two tasks that can be performed separately and actually measured separately. So, dual tasking is important so that the brain learns how to take motor tasks and operate them down in those subcortical motor areas again, rather than making my walking take part of my attention. Same being true for how I would normally brush my teeth, comb my hair, get dressed, finish a button on a cufflink. Most of those would be automatic. If those activities that used to be automatic, including walking and bed mobility, now start to require my attention, that means I'm at higher risk for falling because I don't have as much attention to look out at the world. So we want to introduce dual tasking in people that are recovering from stroke because primarily we don't want them dependent on attention to be able to move. That goes into walking and swallowing and ADLs as well. So we want people to put their movement in the background again, so movement doesn't require the frontal lobe. Attention and dual task rehabilitation is only accomplished when we systematically subject or expose patients to distractions, and they know we're trying to distract them, and they try to compete, elevate their attention up, and keep their performance up even when we're distracting them. We don't allow them to fail every time. we don't allow them to succeed every time. Along the way, they build awareness and they get to realize, oh, wow, that's much more difficult for me when there is a distraction. That helps to build awareness. Ultimately, the main goal is to build procedural memories. Now, procedural memories, in fact, means that tasks that I can do with my eyes closed or in my sleep, or I know like the back of my hand, tasks that are automatic become automatic again only because we forced them to be automatic. So that is how dual tasking improves learning. You learn better and more completely and more automatically if I try to take part of your attention away. So that is the basic premise so that a motor task emerges automatically again. Here is a depiction, if you will, of how the brain talks to itself in different parts. Imagine that your attention center is too overloaded to think about movement because you're having them remember the items they need to buy at the grocery store or the directions for the left and right turns that they need to make. Their attention center is already committed to plenty of information. The attention center says, I can't pay attention to sitting balance or walking balance or how to get out of bed right now. I've got enough to think about. And the basal ganglia, one of the procedural memory centers, says, hey, I used to operate walking. I used to operate getting out of bed. Let me take this over while you stay focused on what we have to remember. So the attention centers push the task down to the basal ganglia, and that's where it becomes automatic again. It is the route by which we shape our skills and relearn skills. Now, granted, some people learn better by watching. Some people learn better by doing. Some people want to hear all about a task before they have to try it. Everyone needs to learn how to self-correct. They need to practice, then self-correct, then reward themselves by getting it right or shape the activity again because of an error. We need reward or failure at a perfectly personalized or what we call precise level. So it doesn't matter whether you like to watch, attempt, or listen, you will eventually need to be able to self-correct, and you will stay engaged, stay attentive, if that degree of self-correction doesn't feel so burdensome that you feel like you're constantly failing. So for an individual to re-automatize the task of walking, not to have to think about it, or bed mobility, how I get out of bed, or dressing, or stirring a pot, or to be able to type again, the only way something can be re-automatized is if we follow all of these ingredients. They need repetitions. They need success. The task needs to be meaningful. They need to care about it. And we give them a degree of measurement that shows them how well they're doing and continues to show them how well they're doing as they are exhibiting a meaningful change. Neuroplasticity causes that meaningful change, that surprise, that reward. Oh my gosh, I nearly did as well when you distracted me. Causes that to be a significant moment in time and causes the individual to consolidate the learning at night. This actually utilizes the remaining neural networks in the brain toward neuroplasticity. So, keeping in mind that a task is going to be re-automatized only when we load people with a distraction. So you might think of distraction-based therapy, the majority of what we need to cover here today, as constraint-induced automaticity. And what does that mean? That means that by taking your attention and putting it away so you can't use it, the brain is forced to use procedural memory centers. Remember, just like we're going to cover in course 3, the upper extremity focus, one activity you can do is called constraint-induced movement therapy. you can put an intact arm in a sling, and that forces the individual to use the affected arm. What we're doing now is taking the intact attention center and occupying it so it can't be used, forcing other parts of the brain to take over. So we need to restore automaticity in walking, in brushing teeth, in doing crafts, and in sport, and in ADLs. Again, as I've told you today, automaticity is regained, the patient is restored when we can have movement operating in the background. And I actually hold the trademark on that phrase here in the United States. This is a very important concept to allow the basal ganglia and the cerebellum to take over so that the attention center can be on the watch out for the world and look for a problem in a sidewalk crack or a toy that your grandson left on the floor. So there's a science to this that involves 4 modes of distraction. Every mode of distraction truly involves cognition. You can also have an auditory, a manual, or a visual. I hinted at this earlier when I showed you a video. So that is to say, the individual that was doing the 4-square step test was having to listen to me say something while he was doing it, then he had to iterate back to me. That's an auditory distraction. If, in fact, he had to memorize the cards that he was seeing, that is a visual distraction. If he had to actually give me advice about how he was going to prepare himself for the upcoming golf tournament, that's a cognitive distraction. If I would have had him sort the cards numerically, that could have been a manual distraction. Remember that all of those that I've stated, even if it was visual, remember the cards, manual, sort the cards, auditory, listen to what I'm telling you, all of those had to require cognition. All of them, all 4 modes are cognition. We can have cognitive distractors by itself when there's no auditory, no manual, no visual, in the example of when he has to speak something from his own mind. That's cognitive. All right, so now what I want to do is hand to you 4 slides in a row that make this practical. This is a slide that represents some clinical examples of what you can do to visually distract someone. Now, out of respect for your time in the 2 hours that we've got, I'm not going to talk you through all 4 of these, but this will be a very imperative slide that you'll want to go back to and look at again when we're finished. I want to make certain that I leave enough time for us to interact, so I'm not going to go through all of these. Now remember, visual could be coins, something that's projected up on the wall, or so forth. Auditory distractions. It's only going to be auditory if they're hearing it while they're doing. If they hear about it before they're doing it, now they have to remember it. That's cognitive. So auditory means you're hearing something while you're doing. And that is me telling you that grocery list or the directions. Manual. Manual could be superimposing an activity that includes dressing my upper body while I'm also walking. Here's some examples of that. Pouring things from a pitcher to a cup. Opening up a newspaper or texting on my phone. Those are manual. Cognitive, again, is giving myself something to think about while I'm doing, but it's not manual or auditory or visual because it's already been delivered. Now I have to hold on to it. Okay? Now, when you have someone iterate a list, it can be very engaging for that to be a list that comes from their own heart and their own mind. If you have a person that is walking or dressing or balancing in a task and they have to tell you the names of their pets that they've owned or the types of cars that they've driven or the addresses that they've lived at. Now that's cognitive, and that's superimposed onto what they're doing. Now, keep in mind that anyone is going to succeed only when they feel that the level of difficulty is something that's manageable for them. And in order to make a task manageable, sometimes we invite the patient in to help to rate how difficult it was, and then to tell us their preference for how difficult they want the future tasks to be. So we give them a degree of autonomy. And if I gave you a task and I said, okay, while you do the 4-square step test, I want you to name to me many different cities in Egypt, and as many as you can, because that's something that you feel is engaging. Now we've done it, and you tell me how difficult that was. Oh my gosh. Well, I felt I did okay, and I rate that as a 5, and they say, now let's make it harder. And now you are permitted, because they've given you autonomy through that permission, to say, this felt hard, but I want harder. Make it harder for me. When an individual gets an opportunity to have a say in therapy, and they get an opportunity to build what is perfectly at the level of difficulty that they prefer, now they're going to elevate attention, elevate intensity, be more tolerant of a higher degree of challenge, and the neuroplasticity comes faster. Research helps us to understand that people recovering from stroke, almost without regard to where the stroke lesion is, will have difficulty with task switching, fluid cognition. They have difficulty paying attention to their walking and paying attention to the world, paying attention to the walking and paying attention to what you're saying. Only through exposing them can we expect to improve this. So if we translate this portion of what we've discussed, we know that dual tasking is like putting a sling around your attention. We know that people only redevelop procedural memories, dressing, brushing teeth, applying makeup, walking, getting out of bed. We only redevelop procedural memories if in fact we challenge them to be procedural and tolerate distractions. We try to give people an opportunity to focus on a task or a goal to be completed rather than onto their body part. We've learned now how to deliver dual tasking across 4 different modalities: cognitive, manual, auditory, and visual. And in fact, we've learned that giving people some degree of autonomy in keeping with the optimal theory of motor learning, you rate how difficult it was. Now, how difficult do you want future tasks to be? That also causes them to engage even further. When we have subsequent efforts in our next session together to talk about pusher syndrome and even more in-depth in right hemisphere dysfunction, you'll see that having patients get distractions and autonomy and external focus is the key to help them improving. Now, keeping in mind, we've also learned today to not give people 100% cues, to let them struggle, let them give themselves some feedback, even if that feedback or solution is not perfect. So we have to reduce and resist the temptation to over-cue, to step in and give advice all of the time. Allow patients to make small, safe errors that will not get them in trouble or harmed or agitated, so that we can patiently allow them to see if they can figure their way out, so that next time they're successful even more quickly. Along the way, we've talked about other forms of cognitive impairment, one of which that we want to cover now is called impulse control disorders. Now, we do know that patients that experience a frontal lobe lesion, especially the inferior frontal lobe, are more likely to have reduced impulse control. The same is also true for the right parietal lobe, as we talked about earlier. The only way to rehabilitate impulse control is to improve patients' awareness. If they are not recognizing the consequences of their actions, they're not going to stop or slow themselves down or think more deliberately. So we see that right parietal and inferior frontal is where these lesions are. So as we translate some big themes, we've learned now how to help people become more aware, and I showed you 8 different ways to help people recover attention. We do know that we have to allow people to make errors, but not so much that they feel burdened, but just enough to help them feel hopeful. Awareness is going to be the key to rehabilitation that gives individuals the opportunity to learn even when you're not there, because they're starting to self-correct. You've learned also along the way about procedural memories. You've learned several different subtypes of procedural memories, and you've learned that we can only rehabilitate those by constraining attention, by offering distractions, by giving repetitions with a degree of intensity. So it takes all of the things that you've now heard: repetitions, intensity, attention, awareness, purposeful activities, reward that I'm successful occasionally, and the degree of intensity that's going to give me a sense of hope and success. So remember, the intensity isn't always just exertion. That helps. It helps to stimulate the brain. It helps to create that lactate, and it helps to actually increase BDNF. But we don't want to get so caught up on physical or exertional intensity that we forget that intensity of difficulty in keeping with this person's preferences is important. Okay? So then we understand repetitions, as we reiterated earlier, are helpful, but by themselves, repetitions without success and failure balance will not work. We learned that intensity is beneficial, but by itself, intensity will not force neuroplasticity. We learned that task specificity is beneficial, but it not only has to be task specific, it has to be person specific, something that this individual wants to engage in again. And along the way, you learned about giving people variety so that they've become adaptable, and that causes them to actually also be more tolerant of attention. You learned about goal direction rather than internal body part focus direction. You learned about 2 different forms of intensity, being exertional and also difficulty. Now let's move forward even more so we can help people that are experiencing apathy and depression as we begin to wrap up our time together. Apathy is very common in individuals that have incurred a stroke. 80% of the people with dementia have apathy. They don't care about how well they've done. Sometimes they're not even aware. There's a high degree of individuals as they age become apathetic as well. We can improve individuals' ability to be motivated to improve in therapy by giving them greater self-efficacy, by showing them that what they're doing is making a measurable difference in their abilities. Now, please understand that people don't learn self-efficacy by you telling them, you're getting better, you're working so hard, this is working for you. People don't learn self-efficacy, they earn self-efficacy. So you need to give them opportunities to succeed and to fail and to try as hard as they can, but not quite set a personal best. When people earn self-efficacy, it sticks with them. And it's something that helps to reduce depression. I didn't think I could improve, but I'm improving. You can't talk people out of the fact that they think they're not improving. You have to let their actions work. And that can work additionally as well with something that I showed you earlier, using predictions. Let somebody predict that they're going to do poorly. Let their actions be up here. And now they have to adjust their awareness and their expectations. I thought I was going to do this badly. and I predicted it down here, but I in fact did better than I thought. Now I have to adjust my awareness. Now I have self-efficacy. Now I'm doing better than I think I was going to do, rather than you just pandering or telling me I'm doing well. Sometimes unmotivated patients do not want to work on improving for the sake of themselves. They, in fact, are motivated to protect other people. I don't want my wife to have to help me. I don't want my son to have to take off work to take me to healthcare. I don't want to have to hire caregivers to come into the home. So some people that would be otherwise unmotivated can actually be motivated to try to protect other people or to protect resources. And so you can see that one of the critical things that we can all learn is, now let's remember how to motivate unmotivated people through gamification, letting them compete, giving them some autonomy, letting them decide how difficult. But also there's another strategy, giving them an opportunity to protect other resources. Gamification is a natural motivator for most individuals, but not everyone. And I've given you some examples here now of how to set up a gamification so the patient competes and elevates their motivation and actually helps them see that they're getting better, i.e. improve self-efficacy. Oh my gosh, that's 4 days in a row now without a fall. It's a new record for me. So you do something that's called gamification through a streak. And a streak is how many days in a row have you gone without choking at a meal? How many hours in a row have you gone without losing your balance? That's a streak. Another way to gamify is to gamify based on points. And one way to do that is, I'm going to count how many steps you take before you set the cane down. Let's see if we can set a personal best today of 45. That is a way to cause someone to actually gamify around a number or points. So here we had streaks. This is called points. And this one is called levels. Streaks, points, and levels are the three main ways that you can have people increase their motivation after a stroke. Oh my goodness, that's the lowest surface you've ever gotten up from since your stroke without help from me or help from your hands. You have levels, or now you are declared to be independent in dressing. That would be another level. All of this goes through the reward pathway, lighting the brain up with dopamine, which actually makes the brain more likely to incur future neuroplastic changes. The reward pathway tells me I just set a new best. He tried to distract me and I was still able to do well. That is my greatest number of days in a row without falling. Those are rewards. That equals hope. Hope causes me to feel more tolerant of future challenges and be aspirational that I can continue to improve. So we have attention goes up, we have dopamine that goes up, and we have neuroplasticity that goes up. Let's field the question here. One new message down here. What if I use streaks and he failed? How to motivate him or her again? Mohamed, that's an excellent question. That is something that's called the near miss effect. So when someone tries to set a personal best or tries to set a new score for a streak and they don't quite make it, they feel in the very temporary and transient fashion dejected. Doggone it. I tried, but I didn't make it. And that can cause them to redevelop further motivation and try even harder to start a new streak and pass it again. So we want people to break a streak. We want people to try for a personal best and not make it. If you had someone sitting on a machine, a semi-recumbent elliptical or a stepper machine, and they're pedaling away, and you say, now let's see if you can make 76 watts, but they only make 65, then you have them go through an off interval, and you say, okay, let's charge it up again. Let's see if you can make it to 76 watts. They generate even more because of that miss. We want the near miss effect because it causes people to become addicted to, and passionate about trying to perform better. Here's exactly what that means, and this is part of what answers your brilliant question. When you are surprised because you don't get a win every time, dopamine goes up. When you try something brand new, succeeding or not, dopamine goes up. That can be meeting a new person, trying a new food, or attempting something for the very first time again after your stroke. Motivation can actually also be improved just by thinking about an activity that you're going to pursue tomorrow in therapy. One of the best things you can do is finish a therapy session with a patient and say, tell me one or two things you really liked about this session, and I'll be sure to include those in our next session. Now they're already appetized for your next session. They're already motivated to want to come back to your clinic on Wednesday. That also increases their anticipation and dopamine. Now you'll recall, as I already stated, self-efficacy, the notion that I can improve, is earned, not learned. And that's because actions speak louder than words. Gamification causes me to focus on trying to beat a new score. And in fact, it helps me because my own experiences, my lived experiences, are going to be better than you telling me that I'm going to get better. So we're going to begin to wrap up now with a few conclusory remarks and your questions. And I have bonus slides at the end, depending on how many questions you've got. So that gives us something in the neighborhood of about 15 minutes to cover questions. First and foremost, I want to make certain that you all know you're welcome and invited to reach out to me by email. If you want to follow me on YouTube and Instagram, great, that's no problem. If you don't, that's also no problem. But also, if you're interested in a book that I've written, that's available in audiobook and also paperback and also electronic. All right, first and foremost, it is your evening. It's nearly 10 o'clock your time. I want to respect and thank you for your time and participation, and I hope to see all of you at one of our future efforts, and eventually me there in person, hopefully by next year, demonstrating to you on your patients how to do this. All right, so now let's go ahead and turn it over to questions, and I want to open it up for all of you.
دكاترة، حد عنده أي أسئلة؟ أنا عارف إن المحاضرة ممكن تبقى تقيلة شوية، ممكن هو الريتم سريع شوية. حاولنا النهاردة إن إحنا نفيجر أوت الموضوع بشكل سيمبل شوية، بس هو الدنيا شوية محتاجة تفاصيل أكتر يعني. حد محتاج أي سؤال عن أي حاجة؟ أي حاجة.
Okay, so I'll start to field questions here. Just keep them coming.
Okay.
Okay. Do I need to define impaired domains or that whole maximize neuroplasticity? So, in fact, all of the activities that you can do can be coupled together to create neuroplasticity. Work someone hard exertionally, challenge them with difficult tasks, but always appreciate the inclusion of tasks that they want to do. Now, Reem, I believe I might also understand the domains of learning, maybe what you're asking about also. So do understand that it's very easy to look at the cognitive, associative, and also the autonomous phase of learning. You don't have to define those, because anyone that is starting to look at and begin to apply the rules is in the associative phase. People that are not applying the rules, which foot goes up the step first, which arm goes in the shirt first, which foot goes with the cane, anybody on either side of that is in the other form, the cognitive phase if they're not there yet, the autonomous phase if they've totally got it. If I need to have you requalify your question, if I haven't answered it beautifully, please let me know. I'm going to go to Isra's question here, who raised their hand. Isra, if you want to unmute, it's totally fine to ask a question, and I'm willing to hear what you have to say.
The first shot, Tim?
I wanted to ask if I'm gate training a patient, and by the end of this session, we managed to get rid of most of the errors they do while walking. But as they're leaving, they go back to their errorful gait. So I was wondering if we can have some applicable examples based on the concepts that we learned today.
Excellent. That's a great question. Our fourth course is going to be on walking, but let's cover your question now, Isra. So the nice thing is, and it's a beautifully timed and very intelligent question, because if I were to tell someone, focus on not swinging your leg out to the side, don't let your leg swing out to the side, then their ability to control that leg swinging out to the side is only as good as what they can afford to pay attention to. So as soon as they walk out into the parking lot and have to watch out for traffic, they have to default back to their way of walking because they can't pay attention to the leg. But in fact, Isra, if I tell the individual, here's how I want you to approach walking, we're going to walk in this session as though you are hitting a wall. And I actually walk them next to a wall so that every time they circumduct or swing the leg out to the side, they hit the wall. And so then I say, when you leave today, I want you to put an imaginary wall on your right side as you're walking. And just continue to walk as though you've got that imaginary wall. And so now they're conducting their walk in an externally focused fashion. Now, Isra, what if your patient snaps their knee back and hyperextends their knee? So now, rather than saying, pay attention to your knee, don't let your knee snap back, that's unhealthy for you or dangerous, I say, now what I want you to do is act like you're walking in a cave when you can. Act like the height of that cave or that room is too short for you to be able to walk. And now they use an external focus and actually walk without snapping their knee back because they stay somewhat bent down. We'll cover a lot of this in the fourth course on walking, but I hope I've given you two different ways to consider that now. We've got many more questions coming in, so I want to address those. Now, Mustafa says, does neuroplasticity continue for a certain period after stroke and then stop, or does it remain present? This has been proven to be more than 5 years post-stroke in upper extremity rehabilitation trials. You image the brain for a person that's 5 to 7 years post, you put them through intense rehabilitation, then you image the brain again and you see the brain has undergone changes. So we at least know that more than 5 to 7 years post-stroke, individuals can still make change. Now I want to cover Kareem's question. Regarding to attention and dual task rehabilitation, do I need it only with patients to complain, patients that have impaired attention, or is it important to achieve neuroplasticity even if the patient doesn't have impaired attention? Kareem, this is a brilliant question. I'm so thrilled to take this. So every individual that has impairments in their motor abilities, even if they don't have impaired attention, can benefit to make their motor abilities automatic again through dual tasking. So you're in fact right to suspect that even without impaired attention, you can benefit from dual tasking. Okay, so now we have another question here, and this comes from Esther. Okay, so I'm going to read the question here now. Okay, Estem writes, firstly, thank you so much for this amazing lecture. Estem, thank you for your time and attention. It's late your time. Your question is, I have a general wonder why there are some patients who respond well to their treatment while others don't to the same treatment. Estem, this is another brilliant question. Here's a few different answers. Number one, no two people that have a stroke are the same. So people are different with their life experiences and their skills before they have a stroke. Now, immediately after they have a stroke, no two people are the same because the stroke happens in a different portion of the brain, and their brains, even in the same location, are not the same, life experiences, and etc. Now let's dive even deeper. Some people have belief in the rehabilitation that they're getting, and so their improvements are elevated compared to people that don't think they can improve. Depression, low self-efficacy, the same treatment can affect two people differently if they have those things different. Finally, in fact, we can see that some people will improve better than others based on not only their beliefs, but in fact, their therapist's ability to engage them. So if I gave you walking training and I told you I'm going to change your brain through this by exerting you, delivering fertilizer to your brain, and in fact challenging you, but the other person got the same exact walking training, and I never told you about the fact that I'm helping you improve your brain, then that person is not going to improve as much either. So the answer is 4 things. Number 1, people are different before their strokes. Number 2, the stroke is different on everybody's brain. Number 3, beliefs. Does this individual believe they're going to get better, believe in the treatment? And number 4, how much does the therapist educate about it or even believe themselves, and how well are they communicating that? Eston, that's a great question. Okay, so now let's see Omar's question. And Omar says, I was wondering if using visual dependence in doing tasks is better for neuroplasticity, such as visual imaging or virtual reality, and which of these techniques is better? Omar, exceptional. The answer is variety. You want to give people time where they have all of their sensations. I can feel, I can see, and also I can use my vestibular apparatus. But you want to systematically give them times where their eyes are closed, or I've pulled a curtain in front of them, or their head's rotating, that forces them to be able to feel with their inner ears or feel with their body because the vision's not there. So we want variety, including times where you can see someone else do what's expected of you, time where you can quietly do mental imagery or visualization. Variety is best. And the nice thing is, much of what you suggest can be done outside of therapy with visualization. Okay, we have time for a couple more questions. Ola asks, how do we determine the optimal repetitions for each task to maximize neuroplasticity? The only way to know this for certain is if the person that you're consistently working with is demonstrating carryover and learning. So I give you an opportunity to practice, I take you away from that task, and then in fact, did you retain it? So that means I at least gave you enough repetitions, but did I give you more than you needed? Well, let me try to get away with a few less. Can you still demonstrate learning? And all learning is neuroplasticity, all learning. Okay, Kareem, great, thank you. Do you recommend any resources for cognitive rehabilitation? So I teach a lot of courses in the United States that you may have access to that are on MedBridge, and I teach specific courses on cognitive rehabilitation. If you want to email me, I can get you links to that. But also, there are many articles that if you search me on dual tasking for articles are on cognition as well. Okay, we have one more question in the queue right now. Go ahead.
Last question, yeah?
Yeah.
Yeah.
This is from Mustafa.
Yeah, from me, okay? I will
Okay,
ask,
go ahead.
if we should introduce dual task training, yeah? It's very important, yeah?
Yes.
What is the best time to introduce dual task at any stage of recovery, cognitive or associative? At any time we should introduce dual task, yeah?
The best time to introduce it is late in the cognitive phase, just to start it, to sample and see how well the individual is tolerating. based on how well or poorly they tolerate, now I start to actually really enfold a lot of dual tasking during the associative phase. So that's when I'm going to do a majority of my dual task or my distraction or cognitive motor interference in the associative phase, because now the patient started to make some gains, they've started to demonstrate some learning, and they're going to be more tolerant of me throwing in some distractions. Yeah. Very good. Mohamed, do you want to say anything else to close us up, to talk about future efforts or anything else?
Yeah, we will organize together more events, show online event or in person or in campus, yeah? We will organize that together, okay?
Absolutely. So we'll do 3 more 1-hour online or remote efforts. We'll do that and watch, follow Mohammed's, I think it's neurology, I believe. I saw that. So follow that, look for more information, and we'll have 3 subsequent ones later on in the year that are 1 hour in length.
That's right, yeah.
Excellent. Thank you so much. Blessings upon all of you. Thank you for your time. And I very much appreciate the opportunity to collaborate with you. And I will hope to make it out to Cairo to teach in person and someday too.